What's up, everybody? Those of you that don't know me, my name is Dr. Matt Meggio. I'm the creator of the Peak Method and the founder of the Soft Tissue Revolution, where we teach massage therapists a new treatment method that focuses on working smarter, not harder, allowing them to make well over $100,000 per year with less than 20 hours per week of time in the clinic. This is going to be my shoulders injury webinar, so let's jump right into it. So I always start these webinars off the same way. How can you ever fix a problem if you don't know what it is in the first place? You know, so much of musculoskeletal treatment, injury treatment is just like, hey, let's just get in there and kind of see what happens. There's not a lot of like evaluation, history taking, really figuring out what the problem is. That's on one side where people are like, just treat this one thing and then see what happens. On the other side is like they overly evaluate it with it. They spend like an hour, 2 hours kind of looking at it, but there's not enough time on the treatment. So my goal is really to get you thinking critically and being able to figure it out. So the goal of the Peak Method is basically the following order. One is to get to a tissue-specific problem list. I've had past webinars on that where you can go through the 7 problems in the human body. That's how we're going to break it down on this webinar as well. Number 2 is we need to restore range of motion, then manage their load, because usually when people are injured, they're doing too much and they're not able to heal and they're having problems with that. Then we balance strength. A lot of that's done with like corrective exercise aspects and things like that. Then we increase strength with overall motion and things like that. And then lastly, we maintain that range of motion with maintenance treatments once we establish what the problem is and what's going on, what the load factors and everything like that. So that's just a breakdown of what the Peak Method is and what the goal really is. So I break this down and I have a webinar about this where I go more in depth about each one of these, but I have what's called our first order history questions, the questions that you must ask every single time before you ever think about doing an evaluation or putting your hands on the client. One is their age, next is sex, male or female, symptom location, where they feel the pain, what is the symptom quality, what does it feel like, is it sharp, dull, achy, throbbing, stabbing, numb, burning, tingling, all of that. Symptom severity, basically what I like to do with this one is I break it down to on a scale of 0 to 10, 0, no pain, 10, you wouldn't care if we cut it off. What is the worst that pain's ever gotten? And then I want to know what it's been like in the last 30 days or so, because I'm looking at this, is it an acute or chronic type of problem? What makes it worse? What makes it feel better? I go in depth more on the other webinar of this. So this is just the basics from where we are. Second order history questions. Have you had any accidents or trauma? Any imaging done? Have you seen any other practitioners for this problem? What did any of them tell you was wrong? Did any of those treatments help? Do you do any working out? What do you do for work? And lastly, how is this problem affecting your quality of life? So I make sure that I ask these 12 questions on every single new client that comes in when I'm trying to figure out a tissue specific list. So what we're going to break down in this shoulder webinar is the 7 problems that I call them, and they go in order. It's a bone problem, a cartilage problem, a disc problem, a ligament problem, a nerve problem, a soft tissue problem, and a tendon problem. And based off of that, we're going to be able to see like what's causing each one of these and just how they all affect in different types of ways. So if you haven't watched those other webinars, maybe go back and watch those first, because this is going to be more specifically geared just for shoulder injuries. So first one, bone. In the bone injury, age is a big factor. As people get older, they put more in wear and tear on their body. They start to get bone spurring in the joint. The bone wears down. This is a big factor in here. Another one that I see is just trauma. Trauma is really big. You know, a lot of people that have had chronic like separations or dislocations, what happens is it puts more wear and tear on those joints and they can't move how they're supposed to. So I see this a lot in people that have had a history of AC joint separations and even SC joint separations. I see way more AC joints than SC. SCs usually take a lot of trauma. ACs are more common where they might have just fallen or jammed it up in a different way. But what happens is when those joints aren't moving how they're supposed to, it puts more wear and tear on the surrounding muscle. So a lot of times, a key question when I'm asking in my history was, hey, have you had any trauma to that area? Or if I'm looking at someone that's maybe like 50, 60 years old, bone is going to be up there as well, because they've just been living for a long time and there can be more wear and tear in there. Next one, cartilage. I always say this, cartilage is very commonly missed in chronic shoulder pain. People miss it all the time. And there's a lot of factors that go into this. One is just symptom location. A lot of times when I have a client that comes in, they might say they feel it really deep inside the joint. A lot of times they might feel it on the side of the shoulder as well. They'll describe it as like a popping or clicking type of feel, and it will be sharp and stabbing. A lot of times if they like go to reach for something, I see this when people like go to put their seatbelt on. I see this in females when they try to put their bra on. If they're like reaching really quick and that shoulder isn't stabilized, they'll get that sharp, like, oh, that really hurts. Intensity usually increases. You know, I see this as like, it gets a lot worse when they do particular movements, like I said, reaching, pulling, trying to do something where their shoulder's not in a good place. Provocative, like what makes it worse? Usually they'll say like it's worse with movement for sure, but a lot of people will say, hey, when I lay on it at night, it really starts to throb and really starts to get achy. Palliative, usually what I see is it's just better when they don't use it, or if they kind of tuck it and keep it in like a very protected and stabilized position. Trauma is going to be big on this one too. Repeated trauma to the shoulder, what it does is it wears out that cartilage. That cartilage basically sits in between the shoulder and serves as a cushion. So anytime you move your shoulder, it wants to move nice and easy. But if there's a lot of trauma, it starts to jam in there. When it jams in there, it starts to fray away the cartilage. And a lot of people will get diagnosed with what's called a slap tear. Basically what that means is the labrum tore in there, and then they'll get called like shoulder impingement and things like that, which don't really tell us much of anything. I'm gonna go over that a little bit later in the webinar. And then just specific activities in sports. I see this a lot in athletes, overhead athletes, people that do a lot of single arm stuff like pitching, volleyball, tennis, things like that. It can get really jammed up and worn down. And then a side note on imaging, a lot of people will get MRIs done of the shoulder, and a lot of times it'll come back as like clean or inconclusive. The problem is the cartilage doesn't show up as much on like a regular MRI. It sure as hell doesn't show up on an X-ray. It usually needs a special type of MRI scan, which is called an arthrogram, where they go in and inject the joint with a dye so you can see it. So a lot of times these are just walking around misdiagnosed, and people get diagnosed with like shoulder impingement, and that doesn't really tell us anything for that. So cartilage is a really big pain generator with this. And when I see cartilage problems, a lot of times when they're like going to lift their shoulder, they'll get there and I'm like, ooh, that doesn't feel good. And then they kind of clear it through and it feels a little bit better. And then it hurts again when they're dropping, but really diving into the idea of like, does it hurt when you're using it more, when you lay down? That's really giving me some suspicions of a cartilage problem. That trauma's in there as well. Disc injuries, you're not going to see those in the shoulder. You need to correlate this with symptom location. So one thing that I teach in my trainings is anything out here or the front part here, this is a shoulder problem. When they get pain back through the traps and through the neck, that is actually a neck problem. And a lot of people will come in, you get clients that come in and be like, oh, my neck hurts. I mean, my shoulder hurts, but that's actually a neck problem. So really correlate with that, because the disc isn't going to be a main problem in the shoulder. It might be a secondary component after you unload the shoulder and figure out what's going on, but really asking those questions like, where exactly do you feel it? And I want to see out here, front, and nothing in back through here. Then I'm thinking more, I have a true shoulder problem. Ligaments in the shoulder, definitely symptom location. Like I said, there's problems with the ligament. There's going to be some part on the back part here, definitely some parts in the front in there as well. And people will usually describe that pain as like a tight, achy, restricted, just kind of feels stuck. Symptom intensity, you know, usually what I find is that it like stays in that like 3, 4, 5, 6 out of 10 range. Usually gets a little worse when they go and use it. It's better with rest. History of trauma in there as well. Like I said, if those AC joints and SC joint have been stretched out with trauma, that can cause some problems in there too. And lastly, just their activity and job. Are they like a manual laborer? Are they doing like a lot of overhead workouts and things like that? That really helps you get a better idea. But ligament is definitely a big pain generator in shoulder dysfunction and overall movement. Next one is nerve. So this is crazy, but there's 256 different places in the body where a nerve entrapment can occur. That's a lot of places. So basically what happens is nerves are built with like 15% of like extra slack to make their way through muscles. They make their way around ligaments, through the joints. And what happens over time is the scar tissue inside these muscles kind of builds up and it acts like glue and these nerves get stuck. So a big thing that I'm always asking is like, where do they feel it? And a lot of times, what does that pain feel like? You know, they'll say it's numb, aching, burning, and there's some tension in there. And usually what happens when there's a nerve problem is like when they use it or they're active with that motion, it'll bring it out. Now there's some really common nerve entrapments for shoulder pain. One is in the brachial cords at the subscap in the neurovascular bundle. That's really common there because with bad shoulder mechanics and chronic shoulder injuries, that subscap gets overworked and that scar tissue starts to lay down, which in turn will put some pressure down on 3 of those nerves, definitely the median nerve, radial nerve, and ulnar nerve. And that's where symptom location really becomes key. You know, when I have a median nerve problem, usually what they'll have is like some problem in the middle part of the forearm here, down here through the carpal tunnel, and then like the 3rd and 4th fingers in there. Ulnar nerve tends to be lateral out through here, in through here, and then on this lateral, a medial part of the elbow in through here. And then radial nerve tends to be in the web of the hand, and then right out here through the lateral part of the elbow. It's really key in identifying that, because a lot of people will get like diagnosed with like carpal tunnel problems. They'll do like an ulnar nerve relocation. They'll do radial nerve things, and they never really address the problem. And a lot of times that's coming from the shoulder. So the key here is like, where do they feel it, and what does it feel like, and does it get worse with certain movements? A lot of times that is causing a nerve entrapment. When the nerve is entrapped, the muscle really tightens up really quick. It almost have like a really sharp stop. Like they might be moving their arm and it'll just stop, because when it pulls the nerve, the body's #1 mechanism to do is to protect the nervous system. Because if the nervous system doesn't work, you don't work. So nerve entrapments are really common in asking those right type of questions. Soft tissue, my favorite thing. Soft tissue components, there's different types of things that you get in there. You can get scar tissue buildup. Basically, scar tissue buildup is like glue that gets inside the muscle, makes the muscle weaker, less flexible. You can also get some atrophy, where one muscle kind of shuts down, doesn't do what it's supposed to do. You can also see some hypertrophy, where one muscle might be working harder than the other. But at the end of the day, those are all soft tissue components. So key here is like, hey, where do you feel the pain? What does the pain feel like? That severity, like it's going to be very similar to the ligament, where that like 3, 4, 5, 6, 7, worse when they're actually using it, better when they sit down. If there has been a history of trauma in there, scar tissue forms over time and really starts to build up. Just a lot of like activities and jobs. I see this a lot with people that have a very sedentary posture, or also people that are like using a lot of their muscles over time. You see this a lot in like blue collar workers and things like this. I tend to see a lot of these problems in specifically the muscles of the rotator cuff, a lot in infraspinatus, a lot in teres minor, and definitely a lot in the subscap as well. They build up and really start to build up over time, and over time that muscle gets weaker and less flexible. So soft tissue is a big component in pain injuries, and it's also the most common problem of that, but also the most reversible with the right type of treatment, proper depth, proper tension, which we teach in the peak method trainings. Tendon. This one is very age related. So over time, what happens is the rotator cuff muscle tendons, the muscle itself doesn't work as well as it should, because it accumulates scar tissue over time. So what happens is the force has to go somewhere, so it goes more on the tendon. The most common tendon to see a problem in the rotator cuff is going to be the supraspinatus. That's usually the one that tears on most people. Then in order is going to be infraspinatus and subscap. Symptom location is going to be really key. A lot of clients will come in with like pain on the top here, on the side here, or down through here as well. Provocative is going to be big on this one too. Usually when they're not using it, it's not too bad, but when they go to reach or do something, it's pretty beat up. Palliative, it feels better when they're not using it. Trauma is going to be a big one here too, because if those joints and those ligaments and those muscles have been working overtime, the force has to come somewhere, so the body always sacrifices the tendon. Activities and job, like what do they do? Are they very active? Are they using it too much? They beat it up over the years. And a key one here, and this one gets missed all the time, is the difference between what's a tendonitis and a tendinosis. So most people get diagnosed with tendonitis, which really doesn't tell us much of anything, just tells us that the tendon is inflamed instead of figuring out why. What really actually happens is this thing called a tendinosis. So basically, if you look at a tendon like under a microscope, it looks like if you got like a box of like pre-cooked spaghetti, it's really strong and it would be hard to break. That's what a healthy tendon looks like. What happens over time is when there's more wear and tear and more force being put in there, the body actually lays down more tendon in there to help buffer the area, and that creates what's called the tendinosis. And if you look at a tendinosis under a microscope, it actually looks like a bowl of like cooked spaghetti, and it's more likely to tear. It doesn't get enough blood flow, it doesn't get enough oxygen. So most tendon tears started as a tendinosis, especially when you got those clients that don't have any real direct trauma, but they end up showing up with a confirmed rotator cuff tear on an MRI. That tendinosis is really important. Like I said before, 97% of tendinoses were, 97% of tears were tendinoses before they begin. It's a big problem in there. So common diagnoses that are completely wrong: shoulder impingement. People get this all the time. They're like, oh, I got diagnosed with shoulder impingement. Doesn't tell us anything. We need to have that tissue specific problem. Is it a bone problem, cartilage problem, ligament problem, nerve problem, disc problem, soft tissue problem, or tendon? We can't just say shoulder impingement. It doesn't say anything. It's very vague. It just says the shoulder's getting stuck. We need to know specifically what structures are getting stuck, what's causing that. Because like I said, if we don't know what a problem is in the first place, we can't fix it. Number two is a shoulder bursitis. This is what I call one of those junk box diagnoses. So anytime you have something with itis on the end, it's just a code name for whoever diagnosed doesn't really know. It's telling us that there's swelling in the shoulder. And most people start with like treating it with like a cortisone shot or going to PT, but that doesn't really do anything. We have to figure out exactly why that bursitis is in there and go and find that. Bursitis is like the idea of like it's the effect instead of the cause. So if we just treat the effect, we don't fix the cause, it's going to come back. Having surgery on a torn rotator cuff, these actually have really poor outcomes. And a big criteria that I look at with these ones was there trauma or not? If there was like a lot of trauma and they got smashed in a car or they got nailed playing a sport, then surgery might be a better option. But most people that I see that end up having a rotator cuff, it's just overuse, repetitive stuff. So they go in and fix the area that's torn that they see on MRI, but they didn't really get to the root cause of what's going on, which is the dysfunction in the rotator cuff everywhere else. So shoulder surgery and rotator cuff repairs is very common, and they have a very poor outcome. So the key differentiator there is, did they have trauma or not? Winging scapula, that doesn't tell us anything. It doesn't give us a tissue specific thing. Hard tissue specific problem of what's going on. Basically what happens is I see a winging scapula as a compensation for a deeper rooted underlying rotator cuff dysfunction, and the scapula wings for a reason. So a lot of people go to like, oh, it must be a serratus problem. We need to do push-up plus, we need to do wall angels and things like that. Instead of asking the question of why is that scapula winging, it's winging because there's rotator cuff dysfunction down deep in the joint, in the muscles and the ligaments and the nerves around there as well. So what are you going to see the most of as a soft tissue practitioner? Definitely scar tissue. I'm going to see a lot of scar tissue accumulation in the muscles, specifically the rotator cuff muscles, infraspinatus, subscap, teres minor. You will see those nerve entrapments in those brachial cords. And a lot of times if there is some nerve entrapments further down in the ulnar nerve, radial nerve, or median nerve, it can limit some of that shoulder motion because those nerves are getting pulled here. So the shoulder kind of shuts down. Ligaments, the ligament you're going to see this is in the posterior glenohumeral capsule. That one is a huge problem that just gets overworked with a lot of scar tissue, and the capsule can't open up. The rest of the shoulder has to work harder, so it does put more wear and tear on the joint, the cartilage, the muscles, and the tendons. Labrum, as we said, labrum is going to be one of those great mimickers of shoulder problems. You're going to see this a lot in people, and that's where you go into those history questions and really dive in of like, was there trauma? What makes it worse? Is it popping, clicking? And then lastly, those tendinoses, they're really common as well. Just because someone has a rotator cuff tear or a partial rotator cuff tear does not mean that they need to have surgery right away. What they actually need first is to get as much range of motion restored as possible to take the pressure off of that. Think of the cartilage and the tendinoses as like your thumb, and it's stuck inside a car door. The car door is all the scar tissue that's accumulated, and we can't give the thumb a chance to heal until we remove that. So when they go in and just do surgery right away, but don't fix the other problem, it's going to come right back. So how does the PEAK method go about treating this? First, like I said, we start by evaluating global motion after we've taken a thorough history. And the first motion that I clean up is shoulder abduction. I don't really care about internal, external rotation. If you can't go like this, the global motion, the other ones don't really matter. And a lot of times those internal and external restrictions in motion are coming from a limitation in just overall global motion. Then we get in there and do manual/instrument-based scar tissue treatment to restore range of motion. And where I'm going to be treating that is in the muscles, the nerves, and the ligaments, where I talked about. We're going to get proper depth and proper tension, break that down, make real, sustainable, effective changes in the tissue and range of motion and mobility. Next one is we got to manage the load of their shoulder. In the basic concept, an injury happens because people did too much. You have this idea called load versus capacity. Capacity is how much you can take. Load is what you do. When load exceeds capacity, that's when you have an injury. So you've got a client coming in and they got a messed up, jacked up shoulder, but they still want to do all the same stuff they're doing before. It's not going to get any better. I would give an example. I'm like, this is kind of like we treat you for diabetes. You do really well in the office, but then when you leave, you eat a bunch of sugar. They have to limit their load because we're fixing their capacity. And if we fix their capacity and they keep doing the same load, we're just going to continue to be where we are, and this problem will get a lot worse. Then we do go into some corrective exercises to the rotator cuff group. We only do that after all the range of motion is restored. We do not start with exercise first, kind of like building a house and trying to put the roof on before you put the foundation. And lastly, after we clean up the shoulder dysfunction, a lot of times what you're going to see pop up is some dysfunction in the neck, and especially in the thoracic spine. I see this a lot in the C6 to T5 area, where there's a lot of dysfunction in there as well, because when the thoracic spine is bad, they inherently roll their shoulders forward and correct their neck. So once we clean up the shoulder, we do have to go in there and clean up the thoracic spine as well. I have a big belief, and I'm a firm believer, that most problems in the human body that aren't trauma related started as a compensation in thoracic spine. But you can't start there. You have to go fix regionally where the problem is and then start to look globally. So that's all we got for the webinar. I appreciate you guys watching. Any questions you have, leave them below and we'll be sure to answer each one of them. We do go over a lot of this, like critical thinking, figuring out what problems is, even demonstrating some advanced soft tissue treatments using manual scar tissue treatment to different areas in our free training. All the information for that is listed below. And lastly, just reach out to us if you have any questions or topics we might like to share, you'd like us to go over or share. And lastly, just share this with anybody that you know it could help, that might help get them on that path to thinking critically, figuring problems out, and really becoming a true soft tissue specialist and a solutions provider. Appreciate you guys watching, and we'll see you on the next one.